Welcome to the presentation of tuberculosis. My name is Joel Nyamuhanga, and we are with Mary Wanjiku and Joyce Nyanga. Okay, our objectives are to explore and understand TB etiology, the causative agent, which is Mycobacterium tuberculosis, MTB, the clinical manifestations, diagnostic criteria, control measures, and treatment. We will be discussing different types of TB, and as TB is worldwide known as lethal and is spread by Mycobacterium tuberculosis. It involves multi-system with the protease presentations. Pulmonary infection is the most common, where TB attacks lungs and destroy all parts of the respiratory system, but it can also attack most of the other systems. It has never been known if the TB Mycobacterium can reside outside human reservoirs. It is resistant to several antibiotics, and it is known to survive very well even in harsh human conditions within the cells.
Unlike active TB, latent TB is not infectious. It cannot be spread from one person to another, and it cannot be seen in chest x-rays. So that diagnostic method cannot be used in latent TB. In latent TB infections, Mycobacterium tuberculosis induces cell-mediated immunity. And if we remember from previous slides, cell-mediated immunity is type 4 hypersensitivity immune response. And when it activates the cell-mediated immunity, it's gonna inhibit the growth of the Mycobacterium tuberculosis, but it's not gonna eradicate it from the system. So it's gonna be there, but it's gonna be dormant for X amount of years or even months. And just to recap, in latent TB, TB lives inside the body, but it doesn't grow. It's in a latent state. The patients or people infected with latent TB don't have any signs and symptoms because it's not active. It cannot spread from one person to another. And like active TB, which is active, grows in the body, it can easily be transmitted from one person to another, and it has signs and symptoms present. So the first contact with the Mycobacterium tuberculosis leads to primary tuberculosis. And this is normally localized in the subpleural area of the lungs, as opposed to latent TB, which localizes somewhere up here. So once this pathogen goes into your respiratory tract, it's gonna localize in this area and form a mass known as the ground focus. This is what it looks like in the tissue, and if you take this is what it looks like in the X-rays. So in 95% of the infected individuals, this ground focus is gonna enter a state of latency, eventually gonna lead to secondary tuberculosis. But in 5% of the affected individuals, we're gonna have active tuberculosis.
The mode of transmission is inhalation, that is you breathe in of infected aerosolized particles where droplet nuclei contain 1 to 3 bacilli gain access to alveoli. Unique lipid content enhances pathogens virulence, making it difficult for alveoli macrophage to eliminate the pathogen. So Mycobacterium has that unique wall that makes it hard for the macrophage to eliminate the pathogen. Mycolic acid makes Mycobacterium TB resistant to chemical damage, dehydration, and limit the effectiveness of hydrophilic antibiotic. It also allows Mycobacterium TB to grow inside macrophages, making phagocytosis difficult for alveolar macrophage. cod factor may directly damage outer alveoli macrophages. So we are going to talk about type 4 hypersensitivity immune response. Solazide mycobacterium droplets are inhaled. Stimulates the helper T lymphocyte and CD4 that is for the immune system, inducing recruitment and activation of tissue macrophage and dendritic cell and neutrophils. This process is enhanced by cytokines produced, which is later used in TB-SC testing, so that whenever the SC for blood testing is done, it's going to show the cytokines that are produced. Recruited macrophages undergo formation of multinucleated giant cell and epithelioid cells, that is granuloma. Giant cell are fused macrophages aggregates are functioning to optimize phagocytosis.
Macrophages and white blood cells are gonna undergo formation to form a granuloma, and this is when 95% of the infected individuals have latent TB, because the pathogen is gonna get trapped inside these granulomas, and it's gonna be inactive for a while. So this is what a histological picture of a granuloma looks like. There is inside with a Mycobacterium tuberculosis pathogen inside, and then there's B cells, CD4 and 8 T cells. There's macrophages and neutrophils around it, trapping inside in the middle and leading into
the colonies of Mycobacterium enter the host and settle into the lungs. What they do is that they trigger an inflammatory response, or cellular response, and this trigger, most prominently in the sides of the lung, leads to the formation of granulomas. That is cellular aggregation constituting macrophages, nucleated giant cells, epithelioids, and foamy cells, granulomocytes, and lymphocytes. And the mycobacterium can infect several cell types, including neutrophils, macrophages, endothelial cells. Once internalized by the cell, the mycobacterium can reside in different cellular compartments, such as phagosomes and autophagosomes. And if disrupting the organelles, mycobacterium can also gain access to cytosol. The host will utilize several cellular and immunologic mechanisms to control the infection, and will compete with a broad range of mycobacterium invasion and virulence strategies that, if they are deemed unsuccessful, then the bacteria survives and start replication. And that's how the replication goes, as they try to combat and fight with the macrophage and neutrophils. Finally, they settle forming granulomas, which basically build up to gompers, which crystallize in the lungs and give the shape of the X-rays that we view when we are actually diagnosing TB.
Remember, bacteria can also be grouped into 3 groups based on their shapes. That's we have spherical, which is a round one. We have spiral, which is spiral, and we have bacillus, which is a rod-shaped one. And Mycobacterium tuberculosis is an acid-fast bacillus, meaning it's a rod-shaped bacteria, and it's normally stained using acid-fast stain. But this is only in some cases. Because of the unique lipid content, it makes it Mycobacterium tuberculosis very, very hard to stain. But some of them can be stained using this acid-fast method. A bit about it again, it's an obligate aerobic bacteria, meaning it needs oxygen to survive and grow inside the host, but it can also be facultative bacteria. So if it lacks oxygen, it can find other ways to grow in the host. It's non-motile, and it's an intracellular pathogen, meaning it needs a host, a human host, to survive. It's also neither gram-positive or negative due to its high lipid content, like mycolic acid, the coat factor, and wax fats.
Lipid content renders Mycobacterium TB. It's resistant to several antibiotics. So when it is treated, it can become resistant. So that's why the prescribers or the doctors usually use different kind of antibiotics. It is challenging to stain and ability to survive under extreme conditions. Manifestation includes cough, hemolysis, that is when someone coughs up blood, meaning that the TB has destroyed lung tissues. Weight loss, someone can have low-grade fever, night sweats, and loss of appetite. And then we have pulmonary or systemic dissemination, meaning that it has spread to other organs of the body.
Common traditional way is the TB skin test. And the results of the TB skin test would normally be followed by chest x-ray. So confirm the results of the skin test, because the skin test is not that specific. And it only indicates either exposure to TB or latent TB. Like we mentioned before, when this white blood cells are activated, the process is enhanced by cytokine production. And especially in tuberculosis, one of the most major cytokines is interferon gamma. And we can use this to test for also TB. Interferon gamma, the assay testing is a bit more specific than the skin tests. And the cytokine levels normally indicate active immune response. This is a good method because with the draw of blood, you can also test the patient for HIV. And unlike the skin test, they normally don't have to come back for multiple readings. Another not so effective method of testing is TB screening questions, but this is normally used in low socioeconomic areas.
The majority of patients diagnosed with TB have a good outcome. Patient groups susceptible to worse outcomes or death following TB infection includes those with extreme age, the old, those who delay receiving treatment, radiologically evidence of extensive spread, and immunosuppression, suppressed patient. Complications are extensive lung destruction, damage to cervical sympathetic ganglia, and could lead to Horner's syndrome, acute respiratory distress syndrome, and miliary spread, including TB meningitis. That is, it can go through the meninge of the spinal cord into the brain and infect, because we know bacteria, if they cross blood-brain barrier and go into the brain through the meninge tissues, they can cause a huge infection. And here you can see the thoracic vertebra that links the lungs, that helps in that is helping send impulses to the lung for response, like breathing. Yeah, they get infected with the bacteria, and the bacteria can phagocytosize them, and they will break the chains of communication with the lungs, and that can lead even to depressed respiratory system, where a patient will not be able to breathe.
Is the latent TB. And what is mostly prescribed is isoniazid, but it must be given with vitamin B6, because when it's given alone, it can damage the nerves, causing neuropathy. So that's why vitamin B is prescribed along with isoniazid. Active TB requires a combination of medications. It's because when it's prescribed, maybe for example, a doctor prescribed one kind of treatment, it can resort to resistance. So so the first line, that is the first group, is isoniazid, and we talked about it being given with vitamin B6 to prevent neural damage, rifampicin, rifabutin, rifapentin, pyrazinamide, and the buta. enthembutyl.